truth is that whether or not we like to accept that, we're all human. So when someone comes in and influences you, you may prescribe a drug inappropriately. So that's where.
The world that allows them, honestly.
Hey guys, welcome to another episode of KLF Deep Dive. I'm here with Tom Siepka. Specifically, we want to talk about the 340B program and the rebates that have come along with it. But to understand that, you have to understand what the moving parts are, who the players are, and to that end, we're going to start by talking about one of the biggest players in the whole space, PBMs. But before we start that, let's talk about the man, the myth, the legend, Tom Siepka. So, Tom, tell us a little bit about yourself.
Sure. So, Darshan, thanks again for having me today. Always great to have conversations with you. So, Tom Siepka, I'm a pharmacist by background and training. Worked in different parts of the healthcare industry for large academic health systems, help partner and work with community health centers, worked with tribes. And I own a consulting company, so I'm the CEO and president of HCI Healthcare Consultants. But that's a little bit about my background. I've touched all of these topics that we're going to talk about, fortunately or unfortunately, maybe. But looking forward to the conversation and especially, kicking it off and talking about the pharmacy benefit managers today.
What are health insurance companies, and are they the same as pharmacy benefit managers?
No, that's a good point. So if we think about insurance, there's kind of almost two sides of it. There is like the healthcare plan. I go to the hospital, I need surgery, I see providers. That is one part of like an insurance program. And then there is the medication part of an insurance program. So I go to CVS or Walgreens or my independent pharmacy, I fill a prescription, and hopefully my insurance covers that. So the in that insurance part is the pharmacy benefit manager, right? So a lot of these health insurance companies, they either own it or they partner with a pharmacy benefit manager, or what we'll call a PBM, to manage that part of the program for them.
So why don't health insurance companies do it themselves? Why do they need a PBM to help them?
You know, pre-PBMs, PBMs were really just processing claims information. There was no true management of the pharmacy benefit or the formulary and medication use. There was more of a transactional process that was happening. And when really PBM started coming into existence, and I think today there's only several major players, but I think if you go look, there's 70 plus versions of PBMs out there on the market. A lot of them, overlays of the main companies. They've kind of emerged to say, medication costs have been increasing over time. The insurance companies are having a hard time dealing with that. So these pharmacy benefit managers came into it and says, hey, we can focus just on the medication component and really manage that expense and liability and help you provide the best care for your patient population by being a specialist in that.
Many people don't realize this. Managing medications is actually really complex.
Very
So
complex, yeah.
it comes down to the fact that a lot of these companies, specifically the health insurers, said, look, we could spend the time, the money, the resources figuring all of that out,
Mhm.
or we hire this company. Initially, that's how it started out. We'll hire this company, they'll manage the actual reimbursement, they'll process the claims. Then
Mhm.
these companies, to process the claims, started making relationships with your pharmaceutical companies, with your medical device companies. And that relationship meant that there was more advantages. So the processor was now able to tell the health insurance company, hey, we can get you a discount. Which company wants to say no to a discount? I wasn't going after it. You go after it. Great. I get a discount on top of that. So
Yep.
my next question, what do PBMs do, Tom?
If you look at core main functions, they manage like what we talked about, the pharmacy benefit for large health plans and employers. So another place where PBMs have really come into being is say like IBM or Coca-Cola or Microsoft. They're working with an insurer, but they'll say, you know what, we're self-insured, where they're liable for the expense, right, for those medications. So they sometimes will go out and pick a PBM separately. So there are thousands and thousands and thousands of drugs on the market, right? Generics and brands, sometimes medications that do the same thing, right? They're in a class of medications. They will go in and say, okay, we're going to use evidence and clinical practice and best practice and come up with formularies of the medications that we're going to help you manage for your population. They develop pathways for these medications. That way it's like, well, have you used this medication first before you use the one that just was on the TV yesterday, right? That costs a lot of money. I think that's where you'll see now, like, and I think anyone who's a patient will see this prior authorizations, right? So as they're controlling the formulary, they're putting in a step process where you must do A before you go to B, before you go to C. So that's the painful process of prior auth that patients and providers and everyone goes through. And as well as formulary restrictions. Are you on the formulary or not on the formulary? So that in a medication formulary standpoint is what they're doing from a formulary management standpoint. They also work with manufacturers, pharmaceutical manufacturers, on a couple of fronts. Inclusion on the formulary, right? Which medications do we want on our formulary we're going to offer into our insured base, which ones we don't, as well as discounts and rebates for those medications, right? They'll also then, I'll put in air quotes, share some of these rebates and discount or offsets with the health plan or the employer, right? Because they are helping manage the program and the cost of it. And some ways to manage costs, like we talked about, is formulary. Other ways to manage costs is there some incentive if we use your medication, which we've vetted clinically, all right? Wink, wink. It's all good. And we're going to get this savings that will help us with the program. We'll talk about sometimes what happens to those savings later, but they also then do the basic stuff that we talked about. So they process all the claims. It's all very electronic today, right? Prescriptions are sent electronically to the pharmacy from your healthcare provider. They support all the members with their questions, prior auth processes, and they also route all the payments, right, and expenses of the plan. So they really do a top to bottom management. But if you look at those big four areas that we talked about, and then doing what they started doing many years ago was just the basic processing, the clicking of the claim, right, having that go through and doing the electronic accounting components of all of that.
Follow our page on LinkedIn.
So I'm going to ask the question, why can't my doctor just prescribe the medication he wanted and get the medication that he thinks is right for me?
Well, I would answer the questions. They could absolutely do that if you're willing to pay for it fully, right? So, the PBM and the insurer will always say, well, if you want us to cover these medications, you must go through these steps. And I think a perfect example of that is the GLP-1s that are used for weight loss today. A lot of strict criteria, but I have family member and friends who said, heck, I don't have any kids. I got one mortgage. I can afford it. I'm just going to pay out of pocket for these things. So in that case, as long as the provider thinks, like you said, it's appropriate, the pharmacy and the manufacturer would be more than happy to sell that to you at regular pricing and get that. And it's actually interesting. You'll see if it's covered by insurance. If it isn't covered by insurance, these drugs costed over $1,000 before. Now they're dropping to $400, $350 if you have no insurance. So there is movement in the market, but it's really about what is going to be covered and paid.
The truth is, and we don't like admitting this as a society, but doctors are influenced by pharmaceutical companies.
Yes.
I work with a lot of pharmaceutical companies. I work with a lot of pharmacists. And the truth is that whether or not we like to accept that, we're all human. So when someone comes in and influences you, you may prescribe a drug inappropriately. So that's where PBMs came from. They came because of the inappropriate influence of pharmaceutical companies on these providers, which resulted in increased cost and a blow up of healthcare costs. So there is enough blame for everyone to share, which is the pharmaceutical companies were trying to influence doctors to overprescribe. The doctors were overprescribing in some cases because they were getting kickbacks in many cases. And the PBM was there to slow it down, to make sure that people follow the pathways, as you mentioned.
Follow our page on LinkedIn.
The only thing I would add to the targeting of providers, and we see it today, right? Watch the world news. I think I did a count one time. I think every commercial except for one or two was a drug commercial. So don't underestimate the power of direct to consumer advertising. One of the few countries in the world that allows it, honestly.
Just us in New Zealand.
Yes, thank you. Yeah, only two. And I wonder why that is, right? So, I've talked to providers and patients don't even have that disease. They're asking providers, they're going in on a visit with a provider and say, hey, how about this drug? And they're like, no, you don't have lung cancer, or you don't have
Restless leg
diabetes.
syndrome. I remember that was the big one with Paxil.
Yeah, I think, if we look at where PBMs has positioned themselves, to your point, a great initial thought, right? Like medications are expensive. People saying, well, the pharmaceutical industry has all these new drugs, but they need to make revenue, right? To pay for research and production and all of that. These are not inexpensive ventures.
What do you think are the ways that PBMs land up costing either the employer or the patient more money than it should? How do they do that?
Well, again, every business needs a margin, right? So if you look at a PBM, they will have in standard agreements, they have per member per month fees for certain functionalities, right? They retain some of these rebates and incentives and discounts as an offset to the business expense as well.
What is the
But
difference between a rebate, incentive, and discount?
that's a good question. Whatever is defined in the language is a rebate, incentive, and discount. And sometimes those shift. There'll be agreements, and I've seen many PBM agreements, right, where the PBM will say we're going to be 100% transparent and share all rebates. So all we'll do is that savings, we're not going to call it a rebate anymore. We're going to call it a discount, or we're going to call it another other incentive.
Right.
So they meet the contractual terms and they reclassify what actually goes into a rebate. Part of the negotiation with, I would think, the manufacturer, because they have the manufacturer over a barrel of it. Because you think how things function today, right?
It reminds me of that game that they play on the street where you keep hiding the ball.
Mhm.
Um,
Yeah.
and that's really what we're talking about. Like no one really knows where the ball is except the only one who's moving the ball around. So we'll
Yeah.
talk about
Which is the PBM, right? Because they control the ball and how many balls and how many shells it's under and all of that, right?
exactly.
Yeah.
So to that end, we're going to have you back on, Tom. We're going to continue
Okay.
this conversation. But before we go, how can people reach you?
They can reach us by going to our website, which is hcihealthcare.net. And there we have contact information. You can send us an email. That's probably the best way to reach us
Okay.
and learn a little bit more about who we are and what we do.
Thanks again for coming on, Tom.
Thanks, Darshan. Pleasure.
Call, click, or email